mention in the chat box. So in today's session, we'll discuss about some ICM core infection control management core components, standards, some reports, challenges and solutions that we face in infection control management and prevention. Okay, in a nutshell. Okay, so infection prevention and control teams, IPC teams, or policymakers are not solely responsible for the implementation of infection prevention and control guidelines, but it is also the responsibility of all the healthcare workers. Okay, and thus it is important that all the healthcare workers should be aware of the IPC core components. Okay, there are 8 core components in infection prevention and control. We'll discuss each of this component one by one. Okay, so all the healthcare workers should be aware of these 8 core components that we are about to discuss. So the first component is the IPC programs. Okay, hospitals should have one full-time trained infection prevention control nurse, okay, focal point care nurse, and or doctor, okay, with dedicated time per 250 beds. For every 250 beds, okay, one full-time, yeah, infection prevention control nurse or a doctor. Okay, you can call them IPC officer as well, infection prevention officer as well. Okay, full-time. They are not supposed to handle any other task. Only infection prevention task is their job. Every 250 beds, one should be there. Okay, hospital administration supports the IPC program with dedicated budget, a multidisciplinary committee, and access to microbiology laboratory. This is what administration should provide to the healthcare workers. Only healthcare workers taking the responsibility will not do. Okay, hospital administration should have certain degree of support for infection prevention and control programs, and that they can do through giving the IPC programs a dedicated budget on an annual basis, multidisciplinary committees from that means from clinical as well as non-clinical. One representative should be there in the hospital infection prevention committee, and access to microbiology laboratory should be there. Every healthcare hospital, healthcare centers, and hospitals should have a microbiology laboratory. Only then you can support the IPC programs. Second component is the IPC guidelines. Okay, incorporate evidence-based guidelines. We have discussed in the past, we have discussed about the IPC guidelines directly from the CDC. Okay, for COTI, CLABSI, VAP, SSI. Okay, we have discussed the guidelines. Along with that, educate, train, and monitor the adherence level of hospital healthcare workers with the guidelines outlined. Okay, just by giving the guidelines, the work is not done. You have to also check, you have to audit, monitor that is everyone following these guidelines or not. Okay, follow evidence-based SOP, standard operating procedures, for hand hygiene, decontamination, environmental cleaning, healthcare waste management, needle stick injuries, injection safety, occupational health, aseptic techniques, triage of infectious patients, standard and transmission based precautions. All these topics I have listed down, they have an SOP, they have a standard operating procedure, which is universal for all the healthcare facilities. Okay. So these are the two components, core components. Then we have the third core component, IPC education and training. Impart IPC education involving the participation of all IPC training for all the frontline clinical staff and cleaners upon hire itself. Okay, as soon as you hire them, first train them and then send them into working mode. Okay, undertake team-based and task-based training such as bedside simulation training. These trainings are conducted annually at all the hospitals. Okay, team-based training means you group all the newly hired staff into a single group and you give them a task. Okay, a task-based training means you give a single task to individual people and they have to do that task, and you will monitor how they are doing it. In a team, you make an infection control team, you give them a task, all members have the same task and they have to work as a team. Okay, task-based training is single task you will distribute to individual members. It's not team-based. Okay. Core component 4, hospital acquired infection surveillance. So surveillance is necessary to direct the IPC interventions for the early detection of outbreaks, which in turn will allow for a timely feedback of results to the healthcare workers and stakeholders involved in the infection prevention administration. So functional surveillance is important because you will understand when and how outbreak is happening. In this initial stage itself, you can identify this is an outbreak, and you can take steps to prevent the further spread of it. Okay, not just how outbreak, but also hospital acquired infections. Okay, all the COTI, CLABSI, SSI, ventilator associated pneumonia, all these infections can be surveilled. Okay, and it should be report based, medical record based. Staff should be trained. Okay, AMR record should be present. Core component 5, multimodal strategies. Hospital administration and healthcare workers should coordinate and facilitate the implementation of IPC activities through multimodal strategies, which means strategies carried out at healthcare settings involves improvement intervention. For wherever you can improve, always keep an eye out for improvement wherever, even if you're doing everything out of SOP based on guidelines, but still some creative improvement you can bring into these topics. Okay, so for hand hygiene, safe injection practices, decontamination of medical equipment, instruments, devices, environmental cleaning, sterilization, disinfection, standard and transmission based precautions, triage, reduction of specific infection in high risk areas of the hospital. Okay, all these areas, improvement based intervention should be carried out throughout the year. Core component 6, monitoring, auditing, and feedback. Monitoring and auditing should be carried out to assess the level of adherence of hospital healthcare workers to IPC standards. Feedback of the results of this monitoring and auditing should be provided to all staff participants from auditing team and hospital administration. It's very important. You should not just monitor, audit, and keep the information to yourself. Whom you were monitoring, which department you were auditing, they should get the results of your auditing as well. Like at least the conclusion of your auditing, the feedback has to be given back to them. Core component 7, workload, staffing, and bed occupancy. According to the recommendation of bed occupancy, it should not exceed the standard capacity of the healthcare facility. No hospital hospital's bed occupancy should exceed. Okay, and they should not admit people more than what they have the capacity to admit. Okay, and the healthcare workers staffing levels should be educate and to patient workload and reduce the risk of hospital acquired infection and AMR, the antimicrobial resistance. Okay, AMR stands for antibiotic or antimicrobial resistant infections. So spacing of at least 1 meter between the patient beds should be ensured, specifically in general wards. Overall occupancy should not ever exceed the designed total bed capacity. These two factors you should look after when it comes to the core component 7, at least 1 meter distance between two beds, and do not exceed the capacity of what total bed capacity your hospital has. If it is 200-bedded hospital, the capacity should stop at 200, not beyond that. Admitting a capacity should stop at 200, not beyond that. And then the core component 8, built environment materials and equipments for IPC. Hospital environment should be clean, hygienic, along with the availability of appropriate IPC materials, equipment that facilitates healthcare activities. For example, safe water supply should be available, separate toilets for patients and staff, color-coded bins for waste management, isolation facilities based on the bed capacity, personal protective equipment supplies, etc. Okay, these materials and equipment should be available. Only then you can follow the IPC guidelines. Without these materials and equipments and resources, you cannot follow the guidelines of IPC. So these were the 8 core components in infection prevention control. Coming to the ICM standards in general, okay, Within one page, if somebody asks you to describe what is ICM standards, this is what you have to say. Okay. So leadership support, visible and tangible support from all levels of healthcare facilities organization for successful infection prevention program, which means budgeting. From financial point of view, budget should be available. From hospital administration's point of view, a hospital infection control committee should be available. Okay. From a human resource point of view, infection control officer, full time infection control officer should be available for every 200 to 50 bedded hospital. So you take any department, they have their own inputs and supporting level. Okay. They have their own way of supporting the infection control and prevent management standards. Education and training of healthcare personnel on IPC guidelines to meet the needs of diversity in workforce and also the type of the facilities. Every staff has to be trained for dealing with a diverse group of people. Okay. Uh, every country you go, you will meet ethnically diverse people, okay, getting admitted. So your staff should also be trained for dealing with a diversity in patients. Okay, so diversity in workforce is also important. Okay, if all the staffs are diverse, it's easier for them to incorporate diverse attitude towards towards catering diverse group of ethnically diverse patients as well. Appropriate IPC education to patients' caregiver about the spread of infection, prevention methods, evaluation of signs and symptoms of and notification. So patients' caregiver should have all these details, at least in bullet points, they should have all these details. Health education should not stop only till patient, but also to the patient's caregiver, specifically if you're dealing with a minor. Okay. Performance monitoring and feedback on the adherence of healthcare workers towards IPC practices and requirements are also looked at. Use of standard precautions like hand hygiene, environmental cleaning and disinfection, injection and medication safety, use of appropriate personal protective equipment, respiratory hygiene, cough etiquette, reprocessing principles. Okay, all these topics we have separate chapters in infection control and prevention management textbook. Okay, so every all these topics have a standard precaution, standard procedure. We will discuss that in detail when we take up the ICM classes. Implementation of transmission-based precautions for suspected patients with transmissible infections like any droplet infection, airborne infection, contact infection. Okay, these are transmission-based infections. So droplet, airborne, and contact infection, they all have their own standard precautions, okay, specific to that their group of transmission, such as diarrhea, meningitis, fever, rash, respiratory infection. Early and prompt removal of invasive devices to prevent hospital-acquired infection. Okay, all the hospital acquired infections are related to some or the other invasive devices like indwelling urinal catheter leads to COTI, central line leads to CLABSI, and ventilators leads to ventilator associated pneumonia. Surgeries will lead to surgical site infection. Occupational health and safety through immunization of the healthcare workers and people who are in contact with the infected patient. Post-exposure prophylaxis after any needle stick injury or in contact with any transmissible cases. Blood-borne pathogen standard precautions, PPE standards, respiratory protections like mask, N95 respirators, TB compliance, tuberculosis compliances. Okay, so these all topics come under the occupational health and safety. So challenges that we see in passing down these guidelines or making people adhere to these guidelines. Failure of the medical staff to comply with IPC recommendation. Medical staff, if they are not aware or not well trained, they will not be able to comply properly with recommendations. Patient-related barriers to infection control and discontinued treatment, poor economic conditions of the patients, lack of awareness of prevention control strategies, non-cooperation of the patients and caretakers. Okay, so these are other challenges. High workload for nurses and laboratory staffs and insufficient motivation among the infection control of staffs. That is another topic of discussion. Worldwide, everywhere, nurses and doctors are facing a high workload. Lack of knowledge of IPC guidelines among the hospital healthcare workers, and an inadequacy of educational and training programs, even though you are conducting training and educational programs, but it is not working well. Okay, you're not conducting quality educational training programs for the healthcare workers, so they will have a lack of knowledge. Lack of nurses, laboratory staffs, infection control specialists everywhere in healthcare facilities. That is another challenge. Lack of IPC equipments and materials, resources you do not have. You do not have proper personal protective equipment or money to buy things. Okay, hand hygiene facilities, place. Am I audible to all? Is my screen visible now? Is my voice breaking? Am I audible? Next challenge is passive surveillance system, under-reporting, not doing a proper surveillance, or whatever reports you have, you are manipulating the reports, not reporting all the all the actual cases, inadequate monitoring system, lack of feedback. Okay, validity of innovative technologies. Uh, you may have innovative technologies in the hospital, but is it as good as it says to be? Okay, you do not know how good is this innovative are these innovative technologies. Okay, so that is the validity of innovative technologies. You do not know properly how well and good or how efficient these technologies are until and unless some uh, near miss events or accidental events happen. You do not know the barriers or the shortcomings of the new innovative technologies. Antimicrobial resistance, we have a separate chapter on that. Okay, superbugs, in short, to superbugs, bacteria as well, not just bacteria, virus, fungus. Okay, they are not reacting to the antimicrobials, okay, as they are supposed to. It's not just about antibiotics, antivirals, antifungals, everything comes under antimicrobial resistance. Solutions. What solutions you can have here? Electronic media and satellite communication for evidence-based researches. Nowadays, whatever evidence-based information you have, it is at your fingertips. Okay, you just have to search for it. Internet has made it that easy. Earlier, it was not like this. Okay, all the published journals, all the evidence-based guidelines and statements are out there. You just have to search for it. Capacity building through structured curriculum in medical and nursing education, on-job training of healthcare workers through workshops, seminars, conferences, CMEs. So try to encourage your healthcare workers to visit as much as workshops, seminars, and conferences as possible. Use of infection control assessment tool, okay, ICAT. You can search it online. You will find the checklist on it. These are basic checklist. Anyone who has the basic training in infection control can use these kind of tools. Very simple to use checklist. Translation of international guidelines into simple local languages so that it can benefit the entire world. And English is not just a barrier for communication later on. Customized surveillance system focused on individual healthcare setting requirement. For example, if it is a cardiac care hospital, surveillance system based on cardiology. Okay. If it is a multi-specialty hospital, all the surveillance system will be required. If it's an acute care center, another form of surveillance system. If it's a palliative care center, they have a separate surveillance system. Okay. So surveillance systems are also developed focused on the healthcare settings requirement. Small hospitals, medium-sized hospital, large hospital, they have different form of surveillance systems. Surveillance information software for antibiotic resistance monitoring and antimicrobial use. You can add these, you can ask your IT department, or you can ask your hospital software um, owners to put this antimicrobial resistant monitoring as well into the hospital software or surveillance software. Low cost point of care or low cost point of care test as a part of laboratory services can be used, which do not need sophisticated instruments or skilled manpower, specifically when there is a needle stick injury. Encourages healthy competition and active participation through feedback and feed forward cycle. Feedback means you are checking something and you give back the information, and feed forward is using that feedback and making healthy changes. Staffing, planning, and distributing workload according to available manpower and resources. Based on whatever manpower you have and resources you have, you can distribute, plan the workload so that nobody is overworked. Nobody has the overload of the infection prevention and control strategies. So based on what manpower you have, what resources you have, cater to only that amount of, or that quantity of patients. Provide basic IPC infrastructure through hand hygiene products, mask, gloves, gowns, and promote safe practices. This through IEC, information, education, and communication. That is using posters, using health education charts, flip charts. You can impart this knowledge to healthcare workers as well as to the patients and caretakers as well. The importance of using personal protective equipments.